So what are the options for patients who have end-stage kidney failure? Well, the options are a kidney transplant, which is likely to succeed without additional therapy if the mutation is in a protein called MCP. And that's because that defect is in the host kidney. It's not a circulating protein. So if it's in the host or the person's kidney, and you replace it with a new kidney from a donor who doesn't have the mutation, you would predict that the disease will not come back. And so far, the evidence seems to be so. On the other hand, if you have a mutation in any of the other known proteins that cause atypical aHUS, they're all circulating proteins. And the kidney, if you will, is a bystander that took the brunt of that damage. And you put a new kidney in, you're in the same environment with that circulating protein. And so you're likely to get recurrent kidney failure. And there's a high risk of failure. And the risk of recurrence, you can see, is actually quite high, up to 80, 90%, depending on the type of mutation. We know the most about factor H and factor I because they're the more common mutations. But I suspect that we will find similar rates of recurrence for the other mutations. And our own recommendation for end-stage renal failure is a kidney transplant with preemptive, meaning before the transplant, perioperative, meaning around the transplant, so that there is enough drug before, during, and after, and to provide the drug long term. Because we don't know yet who can have the drug for a shorter period of time. And we feel safer until we have more evidence in using the drug for as long as we can. If you have a circulating protein defect, a kidney liver transplant is also an option. And the rationale is actually a very sound one. You replace the kidney because that's the organ that is failed and you're on dialysis or you're getting very close to dialysis. And you replace the liver because it's the liver that is, if you will, making that mutated protein that is altered in your genetic code. And so although the liver is ostensibly normal, in fact it is really normal and doing 99.99% of all of its functions just fine, one protein that it's making is abnormal. So you can replace the liver so that it makes that new protein, even though your underlying genetic code is supposed to make a different protein. The genetic code in that new liver will make a normal protein that you're missing. So it's a potential benefit to patients who have CFH, this factor H, factor I, factor B, and C3 deficiency because these proteins are made in the liver. We don't know yet about some other mutations, but it's possibly going to be true for them, and it won't be necessary if you have an MCP mutation. The experience so far is there's been 21 or more such transplants, 19 for CFH, 2 for CFI, 1 for thrombomodulin, I think. The outcomes are improving. I mean, I think parents and physicians were very courageous to proceed with this form of therapy because it truly offers a genuine way to address a very devastating disease. And I think because of the experience of those pioneering physicians and those patients, are now at a stage where that option is available if we didn't have a drug that we could use effectively. And I think we've overcome some of those early technical challenges. And I think in the right centers, with a lot of technical expertise, this is a procedure that I think now has a better outcome than it had in the past. But I think because of the ease with which we can use a drug and because of the fact that the complication rate for a kidney alone is much less than that for a kidney liver, and we do kidney liver transplants for many other diseases as well. Because the complication rate for a kidney alone is much less, it seems to me quite reasonable that eculizumab and a kidney alone is the standard of therapy for patients who have end-stage renal disease.